very quickly, I want you to take just a moment. I'm going to say 2 words, and the first image that pops into your mind. Public health.
Indian Health Service.
Indian Health Service. Okay. You might have an image of a 1950s, 60s utilitarian kind of a brick building, local health department, maybe a restaurant inspector, maybe a room full of maybe a indigent population, immunization clinic, those types of images. Did anyone picture yourself in that picture of public health? Or a pharmacist? A couple people saying yes. That's great. We often don't think of pharmacists, especially people working in hospital-based programs and so forth, as being a part of this picture of community health programming in public health. So my name is Dawn Crane, and I am a public health consultant, a nurse consultant at the Michigan Department of Community Health. And along with my 3 colleagues today, all of whom are public health consultants, as you heard in the introduction, we're here today to do basically 2 things. To describe some chronic disease initiatives that we're working on at the state level, to talk a little bit about how we've envisioned pharmacists being involved in those initiatives, but also to ask for your assistance in maximizing how these initiatives might be rolled out in the state to reach more people. So in the next hour, you're going to hear about 4 projects that we're working on. I'm not sure how to get rid of that little icon on the side. Does anyone know? Mary? Mary's gone.
Drag it.
Click next on it and see if that works.
Look at the slide itself.
Yeah, sounds good. Thank you. I do many things, but maybe technology is on down the list. Anyway, so we want to start today with just a little bit of an overview about community health, and in part starting with this whole issue of, is chronic disease really a public health concern? And do you think about it as a public health concern? So let's start with that general question. And to answer that, we have to think about 3 basic things. Number 1, is there a prevalence? Is this really of a major concern to us as a community, as a society? Number 2, does it have serious consequences? And number 3, could it have been prevented, or could we mitigate it by some sort of prevention or intervention? So today you're going to hear us talking about diabetes, asthma, and arthritis in particular. And in the context of those 3 things, we're going to kind of keep circling back to these 3 issues as we talk about these diseases. Well, we would be remiss as community health or public health folks if we didn't talk a little bit about the macro view. Don't we love our models? But this actually kind of comes at us from the Centers for Disease Control, which is one of our major funders, and Dr. Tom Frieden, who is the director of CDC and has been since about 2009. Dr. Frieden talks about these factors that affect health. And the reason we wanted to show you this model is because this gives us the broad view, but the way Dr. Frieden has modified it is to look at where are we having the biggest impact. Now, as a nurse and as a certified diabetes educator, sort of breaks my heart that I tend to live in these top 2 rungs of this pyramid, this clinical world of counseling and education and clinical intervention, because guess what? Dr. Frieden says that's where we have the smallest impact. But remember, he's talking about this macro view and these population-based interventions. So as pharmacists, we want to kind of give you this view as well, and for you to think about where are you impacting as well. As I drive around town and across the state and working with people, I see certainly pharmacists getting more and more involved in that 3rd rung as you're doing more interventions with immunizations, right? That seems to be something that I'm seeing a greater push. And I'm not sure how you feel about that as a group, but that certainly seems to be something that I'm seeing across the state. But what we're trying to talk about today is having more and more of an impact with our projects and with our initiatives by changing the context, behavior change, helping people to make policy changes, or as a society, policy changes where we have these larger impacts. So thinking about this as the macro view, then Dr. Frieden says, okay, that's the big view. Now, where can we really start to hone in and truly have some, what he calls, winnable battles? And here are the 10 winnable battles that he talks about. Where are we going to put our energies to move the mark? I've highlighted a few where, as a non-pharmacist, as a nurse, I certainly see roles for pharmacists. You could make the argument that you're already involved in all 10 of these, and I don't think anyone could argue with that. But for the purposes of today, when we're talking about arthritis, diabetes, and asthma in particular, I highlighted those few that you probably have common interactions with your clients on a regular basis. And certainly for today, nutrition, physical activity, obesity, and maybe tobacco, when we're talking about asthma, certainly fit into these winnable battles. So again, we're kind of narrowing the focus as we're trying to narrow where we're putting our efforts in the state. And with that said, and with these initiatives that we're talking about today, where do we start? How can we possibly know where to begin with these populations that have these large problems, serious consequences? Where do we intervene? So we've kind of pulled in what we refer to as the chronic disease prevention model. Got to start somewhere. And with the interventions that we're going to be talking about today, they kind of fall into two camps. Primary prevention, in terms of chronic disease, are those folks who we know have risk factors, but they haven't quite yet developed the disease. Prediabetes being, obviously, the one we're going to talk about this morning. Christy's going to spend time talking about that shortly. Secondary prevention are those folks that have already developed the disease, but with intervention, we can perhaps prevent recurrence, or we can help control the disease. This is my world as a certified diabetes educator. This is Tisa's world with asthma, and Megan's going to be talking about this as well in terms of arthritis, but also a broader context of chronic diseases. And then we're always working towards this whole issue of health promotion for people across the state. So hopefully that gives you a little bit of an overview of where we're coming from today. And probably one of the key things that we want to always have in the back of our mind is this. Even though we're talking macro view, honing it in on winnable battles, honing it in further in terms of, all right, let's start with prevention, whether it's for primary or secondary. One of the key messages we hope you take from this is small efforts, if they are significant, we know from the research, can have a large impact at the population level. So wherever you begin in any of these initiatives in terms of supporting them, which is, again, what we're hoping that we can entice you to do and to get involved, wherever you can begin, small impacts can have a larger impact at the population level. And so with that, I'm going to turn this over to Christy Peer, who will talk to you about the Diabetes Prevention Program. Thank you. Good morning.
Technology is great, so we love it. It just takes sometimes a minute to get it up. Here. Good morning. I'm Christy Peer, and I work with the Diabetes Prevention Program in Michigan. And I'm going to spend a couple minutes today just telling you a little bit about diabetes prevention and what's going on around the state. And would love to talk to all of you later about this as well. So you're going to get just a snapshot today and some information about how you can be involved. I hope you'll see some places where you can also be involved. So Dawn talked for a couple of minutes about public health and what and how we justify what the, I guess, tiers of public health are. And so diabetes, so one of the first things she talked about is the prevalence. So prediabetes is prevalent. So right now we're looking at probably 1 in 3 people, 1 in 3 adults, who have prediabetes, according to the National Health and Nutrition Survey, the NHANES survey. So that's looking at clinical data. But that equates to about 7% of our population, of the adult population, who actually know that they have prediabetes. And we also know that prediabetes is a high risk factor for type 2 diabetes, and it's a precursor, and you probably all know this, is that it is a precursor for most cases of diabetes, type 2 diabetes. And now the third piece is really that we actually have some good news, in that we know that we can actually prevent some cases of type 2 diabetes by doing an intervention. And so I'm going to talk a little bit about the intervention today. So while prediabetes is a risk factor for diabetes, there are a number of other risk factors as well, such as overweight, obesity, sedentary lifestyle, and age. As Dawn mentioned earlier, primary prevention targets those people with major risk factors, without disease, and with the aim of preventing that first event. And for many years, public health just focused on secondary and tertiary diabetes prevention, because we didn't have any evidence that we could actually impact at the primary level. So this is all fairly new over the last probably 8 to 10 years, and we don't, in public health, we don't really put energy into something unless we have something that's proven. So the evidence that we have is that justifies addressing diabetes prevention comes from the Diabetes Primary Prevention Study. It was the DPP, and it was released in 2012. They ended the study early because the evidence was so overwhelming, so that doesn't always happen with research studies. And the study was over 3,000 participants. All of those had clinical pre-diabetes. And this was the first trial. They had 3 legs of the trial, and this was the first trial where they really looked at lifestyle change. And that was where we saw a 58% reduction in diabetes, in type 2 diabetes. And the 2 lifestyle changes that we know are associated with this reduction are losing 5 to 7% weight and being physically active at least 150 minutes a week. And that's moderate physical activity. And so the study showed those 2 together. They didn't just show weight loss. Also, what was done later, this clinical study was done, as I said, and released in 2002. And the Deploy study came out in 2008, and that study actually put this evidence into practice. So it actually took the research study and they put it out into the community as a group-based program. So the current diabetes prevention program, which is a lifestyle change program, that is based completely on the original study. It's completely, it's the same curriculum as the original diabetes prevention program study and as the Deploy study. And this is a year-long group-based program set in the community. It's a full year, and the first 16 sessions are once-a-week sessions, so they go for 4 months. Those are called the core sessions. And then they have post-core sessions that are 6 to 8 sessions through the remainder of the year. The CDC has developed guidelines, and I'm going to talk in a couple minutes about those, that for the diabetes prevention program to really attempt to assure quality and fidelity of the program as it gets implemented throughout the country. And I just want to pull up some information about the Deploy study, because you can see I also have the YMCA on this slide. The Deploy study utilized YMCAs to do the group work out in the community. And so the YMCAs, you've probably heard of those programs, and they've been around a little bit longer, and we do have some here in Michigan. And the YMCA at the national level is also setting its own program to assure their fidelity and quality, because all of their YMCAs are pretty much independent. So they've really set up the program to make sure that it's the same program delivered throughout the country under their name. So I told you I was going to talk about the Cdc Recognition Program for a minute, because one of the things that I think as pharmacists you may be interested in is learning a little bit more about how you could become involved in, or possibly even become a provider of this program in your community. And so the recognition program from the CDC, it's intended to standardize the diabetes prevention programs across the country. And so they want most of the programs to look the same, to be collecting the same information, and they don't want a lot of variation. And I'll talk about in a minute why that is. So there's also a hope to get a registry of programs across the country so that there's a referral source for everyone as well. So while the recognition is an attempt to address quality, assurance, and fidelity, we think that ultimately it's going to be a billable service for third-party payers. And so this really, I think, begs the need for quality for this kind of underlying recognition or certification type program. There are some rules and things that organizations must do if they become a recognized organization with CDC. The application process is not very difficult. It's all the other things setting the program in place. The agencies, they need to identify which curriculum they would like to use to deliver this program. The good news is that there is a program, or there is a curriculum that is in the public domain, and it's on CDC's website and readily available. And you should all have these slides as well. So this is you can learn more information at this website. So the organizations, once they've identified which curriculum they're going to use, they actually identify that up front when they apply to become a recognized organization. And then every 6 months they will need to report attendance, weight, and physical activity documentation from their participants. And then they'll also need to give proof that at least 50% of the participants have been diagnosed with pre-diabetes. So that is one of the important things that CDC is trying to regulate with the program. In Michigan, we do have these programs. They're up and running. The program was released from CDC in early 2012, and so we've been really gearing up with organizations across the state to deliver this program. And there are over 16 delivering the program now. That does include some of the YMCAs that are delivering the program. And the CDC program and the YMCA program are basically the same program. They look pretty much the same. They go for a full year. They have the 16 core program sessions and 6 to 8 post-core sessions for a year. And still the same bottom line is trying to help their participants lose 5 to 7% weight loss and to be physically active 150 minutes a week or more. We also have a network of partners, and I think you all had a flyer as well on this, and that has all the locations, and it has contact information for all the programs in the local community. So, how can you play a role? And I'm really happy that we're here today because we've been really busy trying to get this up and going, and we're just starting to be able to actually spread this a little bit more. I think setting the infrastructure and then actually being able to reach out and try to pull more partners in is just great. So I think pharmacists have access to providers to increase referrals of participants. Also, you could become involved as a recognized organization, as I mentioned, and actually deliver the program if that's how you if that's the type of service your pharmacy could deliver. And then linking to the local programs is a great way to be part of an overall team that addresses prediabetes and diabetes risk in your community. And I really encourage you to contact your local diabetes prevention programs because there may be a unique role for you in your community in diabetes prevention that I haven't thought about, that your local program may have more ideas of how you could be a partner. And then finally, I had to just do one little plug for our Diabetes Prevention Conference that's coming up on October 22nd. It's going to be a full-day conference addressing prediabetes and diabetes prevention. This is the first ever diabetes prevention conference in Michigan, so we're really, really excited about that. And lastly, there's some information there for you to contact me. I'm more than happy to help navigate the process if you would like to become a recognized organization. There's a lot of little questions and there are a lot of lessons learned from the programs that have been doing this for a while. And you could also become part of a network. So feel free to give me a call if you have any questions at all, and I can either help link you with local programs or help you figure out if this is a good fit for you to become a recognized organization.
So I'm going to talk to you today about asthma, public health, and maybe some opportunities for pharmacists to fit in. I have some pretty specific things that I think you can do right away and some programs that I think you'll be really interested in. So Dawn talked a little bit about what makes a public health problem, and I think you already know that asthma is a chronic health problem in your community. It's something you see very regularly. In Michigan, 10% of adults and children have asthma, but it's not under good control. Less than 50% of Michigan adults report that their asthma is well controlled, and about 50% of children had used a controller medication in the past 3 months, and that's really not appropriate care of their asthma. We also looked at Medicaid children, and 13% of them were overusing their SAVAs, and I think that's probably an underreport. I would guess that SAVA overuse is higher in that population. Asthma also impacts Black persons and those living in low income. Oh, that was me. Those living in low income households disproportionately, and Bay, Ingham, Saginaw, and Wayne counties have higher rates than the state average. So if you're from that area, you see a lot more asthma. So asthma, as she said, our programs are generally secondary prevention, and That means that we're trying to work with those who have been diagnosed with asthma. We're trying to make sure that they can get back to a normal quality of life, that they're not having continual asthma symptoms leading to airway remodeling, which can cause problems down the road. So the things I want to talk about today include a certification opportunity that I want to make you aware of. I want to talk to you about an asthma management, case management program that's out there, a place where you can go for asthma resources, and, okay, I totally did not do that. And I want to spend some time on the pharmacist's asthma report. If it's possessed, I'm in trouble. I wanted to make you all aware that there is a certification for asthma called an AEC. It's relatively new in the grand scheme of certifications. It's been around for maybe 15 years or so. You become an expert in counseling individuals with asthma and their families on how to manage their asthma and minimize its impact. You can get full details about it at naecb.org. That's the certification board that gives you your credential. There are 153 certified asthma educators in Michigan. Sadly, only 4 of them are pharmacists. A good friend of mine from Traverse City actually did her PhD on using NAECB statistics, and she found that the registered pharmacists have the highest scaled scores across the country. So don't let your fears stand in your way. You're going to do well on the test if you study for it and give it a try. I did not do that. I don't know where to stand. Okay, so it is a difficult test. It does cost about $300. It's good for about 7 years, and after that you can use CEUs to recertify. It used to be you had to take the test over again. They just changed that last month. Pass rate is 68%. It is a very challenging test, but well worth it if you're passionate about asthma and that's one of your goals. Wanted to also talk to you about MATCH, which stands for Managing Asthma Through Case Management in Homes. And it's a program that has certified asthma educators going into the home and helping families get control of their asthma. It includes 3 or more home visits by the asthma educator. They also do an environmental walkthrough where they're looking for triggers that can keep things going. It's not all about the meds. They have to control the triggers too before they can get it under control. 1 or more social worker home visit or consultation. As you know, there's a lot of psychosocial barriers that keep people from getting good control of their asthma. And if asthma is low on their list of needs, it's not going to be addressed. So the social worker can help with that. Also includes 1 or more physician care conferences, and that's where the certified asthma educator goes with the family to the doctor's office so that they all get on the same page. They can create or update the asthma action plan together, and everybody knows what to do. The case manager also makes a visit to the school, daycare, or work as appropriate. Because, of course, people spend a lot more time at those places than they do at their homes in many cases. It is a certified asthma educator providing and coordinating the service. And referrals can be from any source. This is where you come in. If there's one near you, and you're going to find out where they are, then feel free to refer to them. Or you can tell the patient about it. You can refer them directly. They can come from any source. We did do an evaluation of MATCH recently, and it did show that it reduced ED visits by 60%, hospitalizations by more than 80%, improved work and school attendance, and improved quality of life. That's just some of the outcomes from it. It's a pretty impressive program. So that's where it is in the 5 communities in Michigan. Anybody from any of those communities, or are y'all from up here? Yay! So feel free. I've got their contact information if you're interested in finding out. It's also on our website. I don't know if you can see the web address on the bottom, but if you go to getasthmahelp.org and type in MATCH in our search engine, you'll find all sorts of information about it. And this is a benefit to many people with health insurance, especially Medicaid plans in this area. They've worked real hard. It's a sustainable program that way. Okay, so this is the getasthmahelp.org website that I talked about just a minute ago, where you can find information about MATCH. It's a great guideline-based patient, clinician, and practice tools on there. It's got the Michigan Asthma Resource Kit, which has some wonderful patient handouts on asthma, things that you are not going to find in other places, like health insurance and asthma, helping people navigate through that arena. And also information on things like the MDI law that allows kids to carry their inhaler in school. And lots more info on the programs that I'm talking about today. Okay, so I'm going to leave that up there, and then I'm going to attempt to find my other thing. I'm going to talk to you about... I'm going to walk you through the Pharmacist's Asthma Report. This is a brand new tool that we just put together with the help of some pharmacists and asthma educators. Yeah, good, it's showing up well. You have it in front of you. I think that's going to make it just a little bit easier. Hopefully you have it. It's a tool that we're going to use to help you communicate with the doctor about asthma. We know you communicate with them about everything all day long. I got that. But with asthma, we want to make it just as easy and efficient as possible and help them do guideline-based care. So, to fill out the report, and this is a draft tool. We're looking for pharmacists and pharmacies to help us figure out whether this is the best draft of the tool, help give us some feedback about how it works. Let us know if you get feedback from physicians who hate it or love it or would prefer that it was tweaked in some way. And this is how you use it. We have, this is all, oh no, you're not gonna get in trouble, are you? Okay. All of these are drop-down boxes or fill-in areas. And you can put in things, well actually we'll start over here. So you can customize it for your, you can customize it for your pharmacy. You can put in your pharmacy's logo. We don't want this to look like it's ours. We want it to look like it's yours. It's coming from you. We want you to get all of the credit for it. And you would go to, there's nothing under the desktop. Okay.
Try double clicking on it. Up run your favorites. Yep, that's got it.
Well, anyway, it will open this box that will allow you to go to your desktop when you're back at your pharmacy and pull up your logo. You can steal it from your own website and stick it right on there. It's really not difficult. It takes you to that box, which allows you to do it. We've got a nice big spot for it. We realized that you might have, oh no, you don't. No. Okay, we're gonna try it again. All right, so we realized that some of you are involved in, are working at pharmacies that have multiple locations. You might want to put your location's address here or your phone number, other contact information to help you customize it so that they know who it's from. That's important. You're going to put in the provider's name, Dr. Smith. You're going to put in the fax number. You're going to put in the date. Oh, that is so not the date. This is, okay, I don't see a tab button. You're going to put in the date, you put in the day that you're sending it, you're going to put in the patient's name, Wheezy Rider, that's my favorite. Date of birth, let's make this person about 10 or so. This is a drop-down menu. It says the patient's current controller meds. So you're going to want to include all of the controller meds that you're aware of. We realize that people fill things at multiple pharmacies, and you're doing the best you can with the information you have. So there's a lovely list of the controller meds there. We don't want you to have to type in any more than you have to. We want this to be quick and easy. Let's see if we'll just pick Flovent. That's fun. Now, let's say that this doctor is a little insane and has said that it should be 6 times a day. You can type that in. It's nuts, but you can type in whatever you need to type in. Or, come on, you can use the fillable things as well, which are more logical for the drugs. You can also fill in any of these, and there's the drop-down menu for additional meds. Oh, let's just make it interesting. And twice a day. All right. I have noticed excessive use of the following quick relief med. They've been filling their Saba once a month, and you know that, and you know that they haven't been filling their Flovent at all. So you're going to say they've been filling their Prevental. They write PRN orders, I know, every which way, so we're going to have you type that one in. This doctor just wrote it as PRN. Use it whenever you want. And they've been filling it 3 refills per 90 days. You can also include, if there's other relevant medications, you can include them. You could put in GERD meds, you could put in prednisone, oral burst, you could put in allergy medications that are relevant. So whatever made sense for this, for Wheezy. Alrighty. Then we get to the pharmacist recommendations. These are some pre-written things that we think that you might want to say to the doctor. I've evaluated this patient. Sometimes you can catch a patient with their inhaler and their spacer right in their purse. You could say, let me see how you do that. I know you don't have a lot of time. If you do have time, you can go over the devices. That's really great. They need a lot of help with that. And I don't know if you've seen it. I've seen people, do their inhaler over here. I've heard that they've done it back here because, the doctor told them to hold it up and do it, and they misunderstood. My own dad does it upside down because that's the way he understood it was supposed to be done. It's great if you can do some device training. But anyway, you might want to recommend that the patient be reevaluated at their next doctor visit for their asthma. The next one is based on refill history. The patient's adherence to the prescribed controller therapy is suboptimal. The pharmacist discussed the importance of using controller meds daily and only using rescue meds. So those are the kind of things that you can say in a real quick sentence to somebody. Look, you're refilling these way too often. You really should be on a controller medication. I'm going to send a note to your doctor to remind them to get you started on that. The third one's based on reported asthma symptoms. You might want to consider a step up in therapy based on some information below that we'll go over. And of course, patient wasn't available. Mom picked it up. Kid's not there. She's not talking. But you know that there's a problem. You need to send them a message about that. And I know you called them about that, but we're hoping that this makes life easier. This supporting information comes directly out of the guidelines. The guidelines has 9 wonderful charts that you can use. We've tried to condense them down to be very simple and very easy to use. And if you have the time to have a conversation with the client when they come in, you can say, well, how often do you have to use your SABA during the day? How often do you wake up at night coughing with asthma? If you have time, there's a spot for asthma control test score that's readily available online at asthmacontrol.com. It comes in English and Spanish. It comes in pictures only instead of written text, and you can ask them that. So let's say Wheezy. She doesn't have any daytime, or she has daytime symptoms not very often, but man, she wakes up at night 3 times a week. So you would click on this box, that one. And so that puts her, anytime you're over in the highest level with a check is the patient's control level. This patient is very poorly controlled just because she doesn't sleep through the night very often without waking up for her with asthma symptoms. You can follow the column down. You can see the preferred action. This is what the guidelines say to do. If somebody is not very well controlled, they should get a steroid burst. They should increase their step therapy by 1 to 2 steps and consider the comorbid conditions. That's what the clinician needs to look at. Also, of course, they need to talk about adherence. Are they really actually taking it? If they're not taking it, increasing the dosage isn't going to help, or increasing how often isn't going to help. And environmental control. Did she just move in with grandma and grandma smokes all the time? That's going to be a problem. Increasing the medication might need to happen, but what really needs to happen is the triggers need to be under control before the asthma can get under control. Okay, and then the bottom box, again, straight out of the guidelines, is a brief description of what's in each of the steps of the current treatment steps. And you can pretty much look at their medication profile and guess which step they're in. So you would say, okay, we made up crazy things, but we'll say she was in step 3, and that would say, because we've told them that the preferred action is to step up 1 or 2 steps, and they're in step 3, that helps the doctor, who may not be as familiar with the asthma guidelines as he or she should be, know that they need to do what's in these boxes, step 4 or step 5. They're in 3, step up 1 or 2 steps. You sign it, you print it out or not, depending on how technologically savvy you all are. You could just send it off, I know, electronically to some providers' offices, or you can print it off and fax it the way people have been doing for a long time. And that's it. I get a whole minute more. So we're interested in getting your feedback about this. It's a brand new tool. It's being used in 2 pharmacies, and we'd love to see it being used in more. We'd love to get your feedback on it and see if you think it's useful. We think it is, based on some early feedback from pharmacists who have used it. And if you are interested, I think you've got my contact information on the handouts, and that's the best way to get a hold of me. I'd love to talk to you more about it. It's not online at getasthmahelp.org yet, because it's not a finished product, and I hate to put up something that's not a finished product, but I'm happy to send you that. There's instructions that go with it so that everybody knows what you can do with each of the boxes, and looking forward to hearing from you. Hopefully you'll want to give this a whirl.
Well, we're going to move back to diabetes for a few minutes. So I don't think I probably need to make the case for you in terms of diabetes meeting those 3 criteria for it being a public health concern. But I went ahead and put the slide up there. I'm trying to be a good student, so in keeping with our making the case, here's the justification. Also very sad statistics, and never something to make light of, but you heard about prediabetes, and the numbers are staggering in Michigan, and not very satisfying when we're looking at the actual number of people who've been diagnosed with the disease. We're talking about 1 out of 10 of us now in the state, fully 10% of us. So think about that in terms of the number of people you touch every day, because you're talking about, for the most part, a sick population, aren't you? So who knows what the actual percentages of those people that you're seeing every day have diabetes. And in terms of prevalence, very sad that in that less than 10-year period in the last decade, we saw a prevalence increase of 40% in this state. So, and does it have serious consequences? You're all healthcare professionals. I don't think I need to make that case for you, but certainly when we're talking in 2010 alone, over 286,000 hospitalizations in this state were diabetes related. We know it has serious consequences. Work days lost, financial consequences, you name it. And that doesn't even get into the physical aspects for people. So I'm not going to belabor that. Can we mitigate this? Can we prevent serious complications? Well, yes, we all know that we can. And sometimes it's just as simple as some regular physical activity, right? When I say simple, we all know that that's not necessarily easy for people. And so I don't want to use that term lightly as a diabetes educator. It certainly is not simple for everyone, but we know that that can make a huge difference in terms of controlling the disease and making a difference in terms of the effect it has in people's lives. But kind of back to our theme of these public health initiatives and what are we doing about diabetes from the state health department? And what is your role in terms of these initiatives? Where are we asking you to help us out and to maximize the effect that we're trying to have on diabetes? Well, just briefly, my actual job at the state health department, for the most part, is I certify diabetes self-management education programs in the state. Why? Because in Michigan, and some of you may know this, Medicaid has a policy that says you can't get paid by Medicaid for diabetes self-management education unless you're certified by the Michigan Department of Community Health. That's my job. The problem is, the policy was written over 20 years ago when health care was delivered in a very different way. And the policy still says that we can only certify hospital-based or local health department-based diabetes self-management education programs. So, unfortunately, that's what we're dealing with at this point. We've asked them to review the policy. It is being reviewed, but I don't know that that's going to change anytime soon with everything going on in Medicaid right now. But the reality is we have 92 hospital-based programs. Anyone here associated with a DSME program, certified program? Okay, very good. So that's good news. I'm glad to hear that. So we have 92 of them, and as you may know, DSME is considered to be evidence-based. There's a long history, many years, many studies have been done on the impact of diabetes self-management education. And these programs are certified based on the national standards for diabetes self-management education and support. That's what they're called, the national standards. And there are 10 of them. That's varied over the years. We've had as few as 7, as many as 22, but we've settled in at about 10 over the last few years. So I already mentioned the reimbursement for Medicaid. Michigan Department of Community Health will use the same national standards as are used nationally by American Diabetes Association and the American Association of Diabetes Educators. Both organizations use these standards for Medicare reimbursement purposes. Okay, so the same 10 standards are used by all 3 organizations for quality measures. So, unlike the DPP, the Diabetes Prevention Program that Christy mentioned, that is a bit regimented for fidelity so that people get the same product all the time, and you're going to hear a little bit about that from Megan as well in terms of Stanford. Diabetes self-management education, one of the calling cards about it is it's individualized. You can't deliver the same product to everyone because everyone has different needs. Everyone's diabetes is different. You all know that. People are on different drugs, if nothing else. So we have to be able to individualize it. That's why the quality measures are the standards rather than the actual product that's delivered. So where do you fit into this? If we're not talking about the actual product that's delivered, we're talking about these standards. Where do you fit in if you don't work in a DSME program? Well, the Standard 5 speaks to the instructional staff. And in Michigan, we actually still have the requirement that the programs have an RN and a dietitian on the instructional staff. That's a requirement. That's not true nationally. Nationally, you can be a single discipline program, RN, RD, or pharmacist. I'm happy to say, though, obviously we have evidence that we have pharmacists involved in some of the DSME programs, and we now have our first PharmD who's running a certified DSME program in Michigan, an MBCH certified program. That's Erica Ridgway at St. Joe's Pontiac is now our first program coordinator. So, so we definitely have pharmacists involved as instructional staff. We also have pharmacists that are involved in the programs as guest speakers. Sometimes someone from a local pharmacy will come in and do a guest lecture or something like that, or be involved with a support group. But in terms of fulfilling Standard 5, oftentimes the pharmacists are involved, like from the hospital, will come in and teach the medication piece of the DSME curriculum. That's often how the pharmacists are involved. If you are part of the staff, what you're required to do is to provide a copy of your license. Now, here's the bureaucrat in me. Here's the certification person if I were to come and do an audit. You have to provide your credentials, so your resume, copy of your license, and you have to have 15 hours of continuing ed every year in diabetes-related education. So that's something that you have to show in order to meet Standard 5 criteria. That's if you want to be part of this Standard 5 instructional team. But maybe you're not part of this team. You're not part of this formal Standard 5 team. So how might you be a part of this whole integrated care? Because obviously we're at a point, aren't we? It doesn't matter. We can't operate in silos anymore. You can't just be in retail. You can't just be in public health. You can't just be in a hospital-based pharmacy. We have to be in this integrated, fluid flow of care delivery, coordinated delivery of care. From a funder's point of view, from us, for CDC, from a payer point of view, think of patient-centered medical homes, and from our client's point of view, patients expect it anymore, don't they? They wonder why we aren't talking to each other in terms of their care. So if you're outside of this formal certified diabetes self-management education program, how can you be involved? And I see a critical and key point and piece of this process for pharmacists to be involved in what is called Standard 8, or Diabetes Self-Management Support, DSMS. Ever heard of it? It was a new standard in 2007. And it was initiated because, remember, DSME, Diabetes Self-Management Education, is evidence-based. But the evidence has shown us that after about 6 months, people do great, and then it starts to taper off. They're really revved up, they're really fired up after their education, they got it, and then they start to float away. Well, we know from the research that if they get little hits, if you will, of contact, little pieces of support from someone that's meaningful to them, it's ongoing, it's sustained, they'll do better. Their A1Cs will be maintained at a lower level instead of starting to creep up after 6 months. But it needs to be patient-driven. It can't be me as a nurse, as their diabetes educator, saying, come on to the support group. Here's my schedule for the year. That doesn't cut it. It has to be the patient saying, you know what? I really like talking to my pharmacist, and I see her every 30 days. I'll check in with her. I'll tell her what I'm working on. I'll tell her what my goal is. I'll write down her as my plan for my support. Because under Standard 8 and in their diabetes program, they are required, and the DSME staff is required to work with them to identify a support plan, an ongoing support plan. And I absolutely see their local pharmacists as being part of their support plan. So if there's any way that you can connect with the DSME program in your area, offer yourself up, let them know that you're willing to work with the clients that you have in common with them. What does this entail for you? You're probably already doing it, frankly. When you see those patients come in for their refills, this literally means checking in with them. How you doing? Any questions? Excuse me. Any questions? And they had to identify two things: a personal goal, and this plan for support. So to say to them, you said you were going to do such. I heard you were going to do X. You were going to walk every month or every week, or you were going to whatever, clean out your closets as part of your stress management. Just checking in with them as part of their ongoing support is a huge role that you can play as a pharmacist. So connecting with their diabetes program staff and letting them know that you can play that role and that you're willing to play that role so that patients identify you as their ongoing support plan can be very key in this. Other key roles, as you already mentioned, or you already heard from Christy, obviously being a referral source. And this was true for the asthma program as well. If you're aware of the DSME program in your area, please let patients know about it. If you just pick up that they're not doing well for whatever reason, with their medications, with their meters, because I know many of you are involved with their DME, for whatever reason, if you're picking up it's just not going as well as you know it could be going for them, let them know what's available. It's a common misconception that they have to go through the 10 hours. So please don't let that deter you from telling someone about the local diabetes program. Maybe they just need to check in with their diabetes educator for an additional hour or a couple hours to make sure that they're back on track on something, or to go back and see the dietitian. Obviously, number 2 is something that you do on a regular basis, and that's a huge role that you play in terms of medication review and consultation. Number 3 I included, I know that's always a little iffy, and there's always some discussion about take-back programs and proper disposal, but even at the state level, I get phone calls from people across Michigan who say things like, my doctor stopped my insulin, or they changed my insulin, and I've got vials, and I'd like to donate this. People want to do the right thing. People really do want to, not only get rid of drugs they don't use anymore, but they do want to, let other people use them if they can. So if you can have some information available for them, that's very helpful. And then we already talked about the last thing. And I'm sure you can come up with other roles as well. So, very briefly, there's a map that this was also included as one of your handouts. There are 91 stars here. We just certified the 92nd program I mentioned at the beginning. So for those of you who are from the Greenville area, or if you work with anyone in Greenville, Spectrum United, I just certified them in July. So that was our 92nd program. And my contact information as well. So I'm more than happy to talk to you about diabetes self-management education. I also have provider handbooks up on the registration table. Feel free to pick one up if you like. These were published a few years ago, so there's some things in the back. Some of the program information has changed a little bit, but the information at the beginning about DSME is still accurate, the benefit and so forth. So that is available to you. Thank you.
I am Megan Faulkner, and I'm going to talk to you today about Personal Action Toward Health, or PATH. I don't know if you guys have had enough acronyms yet from our presentations, but I'm going to give you a couple more. All right, I am from the Michigan Arthritis Program at the Michigan Department of Community Health, and we are one of 12 funded state arthritis programs. We are currently in our second year of our 5-year funding cycle, and CDC has charged us with focusing on secondary prevention, so people who already have arthritis, and with the goal of preventing progression of their disease, as well as health promotion, so targeting the entire state of Michigan with the goal of preventing the development of risk factors. we use two major interventions to do those things. We focus on physical activity as well as self-management. Okay, so before I get into the nitty-gritties of PATH, I just kind of want to pose a question, and that's whether or not you all have patients that you think could benefit from learning how to communicate with you and their healthcare providers a little bit better. Learning ways to remember to take their medications and manage any side effects that might come with those medications. Or how about how to find credible sources of healthcare information. Everybody seems to be an expert these days, especially if they have internet access, and I think that can kind of be a problem for a lot of people who work with anyone. If the answer to any of these things is yes, then you all have patients that are good candidates to be participants in a PATH workshop. Personal Action Toward Health is the name that Michigan gave the Stanford University Chronic Disease Self-Management Program 7 years ago when we took it on. They apparently did not think Stanford University Chronic Disease Self-Management Program was a catchy enough name. I'm not sure why. But the workshops are delivered in various community settings. They are delivered to small groups of about 10 to 16 participants. They are 2.5 hours long. They meet once a week for 6 weeks, so there are 6 sessions altogether. Workshops are delivered by 2 trained leaders, at least one of which is managing a chronic disease themselves. And the thing that's unique about PATH is that people with all different chronic conditions attend the workshops together. It's not a disease-specific program. Caretakers, friends and family members of people with chronic disease are also encouraged to attend and also can benefit from the workshop. There are 2 disease-specific versions being offered in Michigan. There's a chronic pain version as well as a diabetes version. But even in those versions, about 80% of the content is the same as the chronic disease version, with 20% being specific to carb counting in the case of diabetes. PATH is evidence-based. So what exactly does that mean? Multiple studies have shown consistent benefits or improvements in participants, some of their health behaviors, like increasing their aerobic exercise, as well as being able to manage their symptoms better with their mind. There have also been psychological health benefits that have been seen. Participants report lower depression, lower incidences of health distress, and increased self-efficacy or the confidence in themselves to be able to manage themselves and manage their health and their conditions. Okay, so a little bit about the workshops themselves. Workshops are low tech. No special equipment is required. You don't need a DVD player. You don't need any sort of laptop or anything. Mostly hand-drawn charts are utilized in the workshops. And here's an example of one of the charts that's used in the workshops. The Symptom Cycles is used a lot to show participants that while their disease or their condition can cause some symptoms, a lot of the time symptoms themselves can lead to other symptoms. While arthritis, for instance, may certainly cause pain, pain can lead to poor sleep, which can lead to fatigue, which can lead to depression. So it's really driven home to participants that unless you break the vicious cycle, the symptom cycle, the condition can and probably will get worse. So in order to break the symptom cycle, participants are equipped with what we call a self-management toolbox. The self-management toolbox shows here all of the different skills that participants throughout the course of the 6 weeks are taught. And not only are they taught these things and they learn about them, participants in these workshops also have the opportunity to practice these skills. Workshops are highly participative. So the workshops really give participants the ability to take control of their health by using these tools. They are taught that not all of these tools will always work in every situation. So the analogy is used that just like a handyman's toolbox, sometimes you need a hammer, sometimes you need a screwdriver. You have all these things in your back pocket and you use them when you need them as things come up. So let's, I'll take a look a little at one of the specific skills that's taught in the workshops now, and that's action planning. Action planning is really one of the main concepts of PATH workshops. Sometimes it can be overwhelming when participants or anyone thinks about trying to make a change in their life. It can seem too big and too onerous, and then it's really hard to get started. So action planning is taught in workshops in order to break goals down into more doable pieces, to give participants the ability to be successful at something and gain confidence to make changes in their lives. Some of the tenets of action planning: it has to be something the participant wants to do, not something that their wife who's sitting next to them in a workshop is telling them they need to do. It has to be something they want to do. It needs to be achievable and action specific. And to kind of get at those things, all action plans have to answer the questions: what, how much, when, and how often. So there may be a participant who comes into a workshop saying, geez, I'd really like to lose some weight. And then they're kind of thinking, well, how can I do that? I need to exercise. Well, that's not really necessarily the most action-specific thing. They really get at, well, what are you going to do? Well, I guess I could take my dog for a walk. Well, how much are you going to do that? I'm going to take my dog for a walk around the block. And when are you going to do that? I could probably do that after I eat dinner, get the kitchen cleaned up. And then how often? I'm going to do that Monday, Wednesday, and Friday. Participants are then asked how confident they are that they can accomplish that goal to make sure it's something that's achievable for them. On a scale of 1 to 10, they need to be at least a 7 or higher. Otherwise, they're asked to modify their action plan to something that they think is more achievable. Action plans are set by all participants as well as workshop leaders at every workshop. Then the following week, everybody comes back and reports on how they did. So there's an accountability factor there. If a participant was not successful with their action plan, leaders will help them identify what the barriers were, and sometimes the group will be brought in to help those participants brainstorm ways to either overcome those barriers or modify their action plan and come up with something they think they can be successful at next time. This activity really allows participants to build on little successes in order to feel more confident overall and take on bigger goals. Okay, so where are these workshops? Well, they're all over, and it's growing, and we're really, really excited about that. PATH came into Michigan in 2007, and slowly over time, we've just seen a real increase. In 2012, yep, that's my data there. 2012, there were 287 workshops held in the state. You can see the green counties there are the ones where workshops took place. That was 70 counties out of Michigan's 83. We have a goal to get in every county. Some of them are a little more difficult than others, where we get into more rural areas. But of the 287 workshops, there were over 3,300 people that participated in a workshop in 2012. So we saw the scientifically proven benefits earlier, the evidence-based, the reason CDC funds our arthritis program to support PATH. But I think it's important to kind of look at what people in Michigan have to say. What are the people in the actual workshops thinking? Well, 99% of them would recommend this workshop to family and friends. I think that's huge. You don't see that in a lot of programs, and we're really, that makes us confident in promoting this program. A couple of quotes there just from things people wrote in on forums from workshops. Makes you stop and think that the only one responsible for my own health and well-being is myself. This workshop inspired me to continue working toward wellness for the rest of my life. And thank you for refreshing and reaffirming things that I knew but wasn't necessarily doing. Workshops they're not really designed to teach too much about health and health conditions. Rather, they're designed to teach people how to manage their health and health conditions and how to seek help when they need it in order to do those things. So what can you do? Because now you think it's great, so what can you do? You can promote workshops in your pharmacy. We have a really snazzy brochure here that we have printed at Michigan Department of Community Health. I left a whole bunch on the registration table, and I am more than happy to distribute some out to anyone. We have had other pharmacies in the past that have placed our brochures in areas frequented by potential participants. You could refer patients with chronic conditions, any chronic condition, to a PATH workshop. www.myhealthyprograms.org is our partnership website. There's a ton of great information about PATH on there, but there's also a searchable database where you can look by county or by city, and there's a complete listing of upcoming workshops you can find in your area. On that website, we have a little brochure template where you could put in the info about the upcoming workshops, slip it into a brochure, and throw it in the bag with any participant you think might benefit. As pharmacists, you really have the unique opportunity to not only communicate with the patient, but sometimes with their other healthcare providers as well. Just spread the word. I know I've heard from other pharmacists that patients have attended workshops and told their pharmacist about it, maybe not even necessarily their physician. So if you're hearing that and there's good feedback, contact a physician, or when you come across someone that you just happen to see, tell them, look, this is out there, this is an option, and this is something that could really help a lot of people. And then if you're really interested, you could hold or sponsor PATH workshops. We've also had a couple pharmacies do that, some that have had staff actually trained and to lead the workshops, and then some that have sponsored the workshops. So in each workshop, there's a snack provided. So a pharmacy may provide the funds or the snack itself for that. We can link you to community partners if you're interested in getting involved at that level. We have a Michigan Partners on the Path as our regional group. We have 7 regions in the state, and so it's broken up geographically, and each region has a coordinator. So we could get you in touch with that person, and they could help you if you wanted to, get to the point where your pharmacy holds workshops or you send people to be trained. And then here are the resources we have available. myhealthyprograms.org, can't say it enough. The brochure, as I mentioned, we have a lot of support for new leaders, like a new leader kit, the regional coordinators I mentioned, as well as technical assistance. It's a huge part of my job, is to support our partners that are implementing or promoting PATH. So we're here at the Michigan Arthritis Program to offer support in that. There is my contact information. I think you guys have it on the slides. And I think we have some time now to open it up if anyone has questions for Dawn about public health in general. Good luck with that. The DSME program, Tisa with the PAR program, and or Christy with DSME or me.
So these are free for
The PATH workshops are almost exclusively offered at no cost to participants. There will be a couple in some areas where they ask for a small donation, usually $5 or $10. Anyone?
I'm going to put in one other shameless plug then, while people are thinking about questions.
I like that.
Megan mentioned the partners, statewide partners program for the arthritis program in PATH. The diabetes also has a statewide coalition, the Diabetes Partners in Action Coalition. I don't know if you are familiar with it or have ever heard about it. It's DPAC. We do have a number of pharmacists who are involved in our coalition. So DPAC is on the website, Diabetes Partners in Action Coalition again, and we welcome members from across the state as part of the statewide coalition. There are 5 work groups that are involved, we have pharmacists. One of the co-chairs for my particular workshop, the training and education work group, is a pharmacist. So we certainly welcome your participation in the statewide diabetes coalition as well. So just wanted to put that in. So anyway, any questions, or is everybody just really hungry and ready for lunch? That's okay too. So. Well, thank you very much, and we really do appreciate the invitation and being able to participate in your meeting today. So enjoy the rest of your day.